സാറിനെ ഓൺ ചെയ്യുവാണേ. ഇപ്പോൾ ഓൺ ചെയ്യുന്നു. കാരണം ഞാൻ ഷെയർ ചെയ്തതിന് കാണിച്ചു. ഇൻട്രൊഡ്യൂസ് ചെയ്യുന്നത്.
Okay. So, good evening, everyone. We will be discussing CA oral cavity today, and for this we have Professor Venugopal M, who is the head of Department of Radiology, Regional Cancer Center, Trivandrum, with us, who will be discussing the cross-sectional imaging for carcinoma oral cavity, and this session will be followed by the management overview, which will be taken by Dr. Cessal Kainickal, who is the additional professor in head and neck oncology, Regional Cancer Center, Trivandrum. So we welcome you all, both of you, sir, and thank you so much for giving your precious time to educate us all.
Can you stop sharing it?
Yes.
Okay. Thank you. Can you stop sharing the screen? Yeah, thank you. Can you permit to share the screen? Yeah, thank you, thank you.
Good evening, everybody. Today, just we will have a short discussion about oral cavity and some lesions pertaining to oral cavity. And coming to oral cavity, when I am talking about oral cavity, I am not going to tell anything posterior to posterior border of hard palate, and also posterior to anterior pillar of palatine tonsil, and also posterior to sulcus terminalis on tongue. So in another way, actually, all these are actually the borders of oral cavity. So today I will be just touching the oral cavity alone. And coming to oral cavity, you know the parts of the oral cavity, starting from lips, gingivo-labial sulcus, gingivo-buccal space, gingivo-buccal sulcus, oral tongue, sublingual space, floor of mouth, retromolar, trigone, and hard palate. So the investigations pertaining to oral cavity are, one is CT, second is MRI, and also ultrasound is rarely used. The role of ultrasound is very limited, and this is useful for assessing the cervical nodes, that is the texture of the node and any extranodal extension. This can be evaluated, and also the tongue lesion. Regarding tongue lesion, we can measure that depth of invasion of the lesion, and also you can do guided biopsy of parapharyngeal masses using ultrasound. So these are only certain indications for doing ultrasound. And the main modes of investigations are CT and MR. And as you know, CT gives good delineation of the structures, but the more important one is better assessment of cortical bone destruction. So many times actually we have to assess the cortical bone has been involved or not, because immediately it becomes stage T4. So CT gives that assessment, but MRI has got certain advantages. One is to know the bone marrow involvement. Second is perineural spread. But the thing is that actually, suppose the dental amalgam is there, the dental artifacts can happen in both investigations. So that's one of the drawbacks. And CT, you are giving contrast. First contrast is given, followed by saline, and then one maneuver actually you are asking the patient to do, that is puffing the cheek out. So that is very important to delineate or to distance the vestibule. And we are scanning from pituitary fossa to aortic arch. Suppose some artifacts are there from the dental amalgam, then you can actually rescan along the line of mandible. So in that case, these artifacts may get reduced. And MRI, of course, T1, T2, and T1 contrast basic sequences. And sometimes diffusion weighted sequence also may help. And T1, all these sequences in axial and coronal planes. So here we can see the advantage of doing this maneuver, that is puffed up cheek. So you can see the vestibule is being distended with air. So you can see the lip, the sulcus, the mucosa, gingival mucosa very clearly. So this is puffed up cheek. And coming to the oral cavity proper is there, vestibule is there, and the lips. See, lips in CT, in sagittal plane, we can see the upper lip, lower lip, and the sulcus. Upper gingivo-buccal sulcus and the lower gingivo-buccal sulcus. And here there is a lobulated enhancing mass in relation to the lower lip. So this is carcinoma lower lip, and in the sagittal plane you can see the mass. And here this is carcinoma. It is not confined to lip alone. It is extending posteriorly to fill the lower gingivo-buccal sulcus that you can see here. And the lip, actually the lesion is involving the muscle in the lip, that is the orbicularis oris, and it can involve the skin inside the buccal mucosa and mandible or maxilla, depending upon the site with which lip is involved. And here there is a lesion in the lip, and the mandible is there, the mandibular arch is here. So I am seeing a small defect anteriorly. I'm not sure whether it is erosion. So if it is erosion, it becomes immediately T4. But what is this actually? Whether it is erosion or something else. When I look at the other side, I can see the same defect on this side also. So that means it is symmetrical. So in that case, this is something else. It is not actually, it doesn't seem to be pathological. And this is nothing but Mendel foramen. So this Mendel foramen should not be mistaken for cortical destruction, especially in case of lip or gingivo-buccal sulcus. And coming to the vestibule, so we can see the GB sulcus, upper GB sulcus here beautifully, and the lower GB sulcus here. And the mucosa is very thin, and here we can see thickening of the mucosa, which is enhancing. So here there is a lesion. It is carcinoma in the lower GB sulcus, gingivo-buccal sulcus. Coming to gingiva, see here, this is the mandibular alveolar process, and here we can see enhancing soft tissue mass over the alveolar process, which is extending laterally to gingivo-buccal sulcus here, and also medially to gingivo-lingual sulcus. So it is extending on either side. And in the bone window, in CT, in the bone window, we can see the cortical destruction very beautifully. So it is a T4 lesion. And here we can see lesion in the upper alveolus with erosion of the floor of the maxillary sinus, small dehiscence is here, and there is slight extension. The entire lesion is actually not the lesion, it is a part of the, it is actually inflamed mucosal thickening, inflammatory mucosal thickening. And this is post-op status. You can see the antro-oral fistula, large fistula, the entire part has gone. So here, sometimes you can come across problems with edentulous teeth. Suppose the teeth are not there. So here on the right side, on left side, I can see the teeth sockets. So these are the sockets. So suppose a lesion is here nearby. So I am not sure whether this is erosion, cortical erosion. But on the other side here, I can see a lesion in the gingiva and see the destruction here. So here I am definite there is destruction because actually the shape has been changed and the in between that bone has been destroyed. So here I am sure, but sometimes again that can produce confusion. So coming to tongue, see the oral tongue, the parts you know, the tip of the tongue, the dorsal surface, the ventral surface, and the root of the tongue, and this is the posterior 1/3 for the base of the tongue. And the tongue actually it is made up of intrinsic muscles. 4 intrinsic muscles are there: superior longitudinal, inferior longitudinal, transverse, and verticalis. The intrinsic muscles, they don't have any attachment to adjacent bones. And also there are a few 4 extrinsic muscles. Extrinsic muscles: genioglossus, hyoglossus, styloglossus, and palatinoglossus. So the last 2 are actually very slender muscles, not very important as far as cross-sectional imaging is concerned. But these 2 muscles, genioglossus and hyoglossus, are very important, and one is supposed to know these muscles and where it is seen. One should know. So here you can see the hyoglossus originating from the hyoid bone, and it is reaching on the lateral surface of the tongue, and the genioglossus from inside the symphysis mendae, and it is fan shaped and it is reaching the dorsum of tongue. So these 2 muscles, hyoglossus number 1 and number 2 genioglossus. And the hyoglossus, how it will look like in cross-sectional imaging. So this is MR T1 weighted imaging. So here you can see the hyoglossus muscle as arch-like. So this is the hyoglossus muscle on the lateral aspect of the tongue, the hyoglossus muscle. Okay, the muscles are seen as iso-indents or grayish in T1 and T2 weighted sequences. So these are hyoglossus muscles. So this from the hyoid bone on the lateral side of tongue, and it is reaching here. And the next muscle is genioglossus. So you can see the fan-shaped muscle originating from the genial tubercle, upper genial tubercle. There are actually 2 genial tubercles, upper and lower, and this is arising from the upper genial tubercle, and this is going to the dorsum of the tongue. It is reaching the mucous membrane of the tongue, and some fibers are going like this, and then posteriorly, and some fibers are going posteriorly, far posteriorly, and it reaches the hyoid bone. Okay, so this is genioglossus muscle, and in MR you can see the genioglossus. So this is the genioglossus. You can see the fibers from the genial tubercle from inside the symphysis mendae, and it is fan shaped, directed towards the intrinsic muscles of tongue. And just note this point: it lies lateral to lingual septum. So what is lingual septum? So this is the lingual septum, and the lingual septum is identified in MR or in CT as fat density. So here it is seen as hyperintense signal. So it is exactly in the midline, and you can see the muscle on either side, the genioglossus muscle on either side. So here you can see the lingual septum in the center, paramedian the genioglossus muscle, and further lateral you can see the hyoglossus muscle. So these 2 muscles actually one is supposed to identify. Then root and base of tongue. So whether they are same or different, root and base of tongue. Actually they are different. Root is actually, it consists of the lingual septum as we just saw, and also the extrinsic muscles, these 2 muscles, genioglossus muscle, not hyoglossus muscle, genioglossus muscle, and also another muscle, that is geniohyoid. Actually that forms the floor of the mouth, geniohyoid muscle. This is not part of extrinsic muscle of tongue, geniohyoid. So geniohyoid, genioglossus, and lingual septum form the root of the tongue, whereas the base of the tongue, as you know, it is the posterior 1/3 of the tongue, posterior to the sulcus terminalis. That is part of oropharynx. So here we can see an enhancing lesion along the left lateral border of tongue, this one, and in the coronal, this one. So the tongue lesion, it can involve the intrinsic, extrinsic muscles. It can invade the neurovascular bundle. It can go down to reach the floor of mouth, and it can extend laterally to reach the mandible, and it can cause cortical erosion of mandible. So coming to hard palate, so there are two bones which are forming the hard palate. One is the palatine process of maxilla, and second is the horizontal plate of palatine bone. So these two bones, they form the palate. Please note two foramina here, the greater palatine foramina and the lesser palatine foramina. So these are in the horizontal plate of the palatine bone. And here, this is the hard palate, and here you can see an enhancing mass, and this mass is producing destruction or dehiscence in the hard palate, and it is extending to the nasal cavity. So this is hard palate lesion. And then coming to retromolar trigone, actually this retromolar trigone actually is very important, because most often you come across lesions in the retromolar trigone. This is one of the preferred sites of carcinoma. And suppose somebody is asking you, what is retromolar trigone? What you can say? Just I am asking whether it is a space, or whether it is mucosa, or whether it is bone, that is the angle of mandible or the anterior border of ramus. So what it is actually? The retromolar, by the term retromolar trigone. And one more thing, whether the retromolar trigone space is confined only posterior to the lower third molar tooth. So that means here, if lesion is seen here, then I can call it as retromolar trigone lesion. Suppose lesion is here, somewhere here, whether it is a retromolar trigone lesion, or whether if the lesion is here, posterior to the upper third molar tooth, whether it is a retromolar trigone lesion. So what is your answer? So lesion occur anywhere between this area, between the upper third and the lower third, that is retromolar trigone. So in other words, the retromolar trigone, actually it is the mucosa. Where is the mucosa? This mucosa is actually lying over the pterygomandibular raphe. Then what is this pterygomandibular raphe? Pterygomandibular raphe is nothing but it is thickened fascia between the medial pterygoid, the lower end of the medial pterygoid. There is a hook-like thing, that is the hamulus of medial pterygoid, and from the hamulus it is extending down, and it reaches the mylohyoid ridge on the medial side of the mandible. So it is attached to the posterior part of the mylohyoid ridge. So that is the pterygomandibular raphe. And the mucosa covering over the pterygomandibular raphe is the retromolar trigone. So that means lesion anywhere occurring between this lower third molar and upper third molar is the retromolar trigone lesion. So in CT, you can see the mass here, that is in the angle of mandible. So it is in the retromolar trigone area. And at the same time, you can see thickening in the buccinator muscle here. So this is in the buccal space, buccinator muscle. Okay. So the retromolar trigone lesion actually is extending to the buccinator muscle. The buccinator muscle is thickened. Okay. And one more thing, here posteriorly you can see the lateral wall of the oropharynx. This is actually oropharynx. The lateral wall of the oropharynx is thickened. So on one side you can see the buccinator thickening. On the other side you can see the lateral wall of the oropharynx thickening. So why it is happening like this? So there are two ways by which you can get this sort of spread. One is the lesion can, the lesion is, just remember the lesion is over the or at the retromolar trigone. So it is over the mucosa. It can very well infiltrate the pterygomandibular raphe. Okay. Once the lesion reaches the pterygomandibular raphe, it can easily go to the buccinator muscle. It can easily go to the buccinator muscle. Similarly, it can easily go to the superior constrictor muscle. So how it is possible? So we can see this picture. We can see the pterygomandibular raphe from the medial pterygoid plate to the inside of the mandible. This is the pterygomandibular raphe. And the buccinator muscle, this is buccinator muscle, it is attached to the pterygomandibular raphe. Similarly, this is the superior constrictor, this is attached to the pterygomandibular raphe. So both these muscles are attached. So the lesion, once, whether the buccinator muscle is involved or whether the superior constrictor is involved or whether the pterygomandibular raphe is involved, whatever it is, it can spread like this. It can go to the buccinator, it can go to the superior constrictor in both directions. So actually this anatomical continuity is very important. So that will explain why there is preferential involvement of buccinator muscle and superior constrictor muscle. And also there is another route that is, of course, clinically you can see that is from the retromolar trigone area, it can go to the anterior pillar, anterior fossas, and from there to palatine tones, palatine fossa. So like that also it can spread. So these are the two ways. Sometimes the mucosa may be intact, still it can involve the superior constrictor muscle. The mucosa may be intact. Clinically, you won't see any lesion in the oropharynx. But when you take cross-sectional imaging, you can see the thickening of the superior constrictor muscle. So the imaging is very important. And another doubt, that is retromolar trigone mass, it is infiltrating medial pterygoid muscle. Infiltrating medial pterygoid muscle. Why not lateral pterygoid? Lateral pterygoid is not involved. You know the lateral pterygoid muscle, medial pterygoid muscle, from where it is originating, from the lateral pterygoid plate, medial pterygoid plate. Okay. And the retromolar trigone mass is infiltrating, usually if it extends, it infiltrates the medial pterygoid, not the lateral pterygoid. So why it is happening like that? That is only because the orientation of the muscles. See, the lateral pterygoid, from where it originates? It originates from the lateral pterygoid plate. So you can see the base of the pterygoid, medial pterygoid here, lateral pterygoid here. So the lateral pterygoid originates from the lateral pterygoid and it reaches or it inserts onto the condyloid process of the mandible. See here. Okay. Whereas the medial pterygoid arises from the pterygoid fossa. It is not from the medial pterygoid plate as such. It is from the pterygoid fossa, and it comes down laterally, goes laterally, and it inserts onto the inside of the ramus of mandible. So it extends down. Or in the coronal plane, you can see the lateral pterygoid muscle. It is having somewhat horizontal course. So it's going like this. It's starting from here and it reaches the condyloid process here. Okay, horizontal way. And the medial pterygoid, from the pterygoid fossa, it is coming down, it reaches the lower part of the mandible. Okay, somewhat vertical course or oblique course. So that means, you know, the retromolar trigone, actually it is down. It is starting from the lower part of the medial pterygoid plate. So that cannot usually infiltrate the lateral pterygoid, but it can involve the lateral pterygoid when it has reached up to the skull base. That is different. But to start with, it will involve or it will infiltrate only the medial pterygoid. So this can be explained if you know the origin insertion of the pterygoid muscles. And here in MRI, we can see the retromolar trigone lesion here. So this is T1 lesion. T1 lesion. This is iso-intense lesion. It is almost the intensity is same as that of the muscle. And here we can see the lesion is enhancing. So that is the importance of giving contrast. In contrast, actually, the lesion will become well delineated. And here the lesion is actually confined to the retromolar trigone. It is not extending to the buccinator muscle. It is not extending to the buccinator muscle, and also it is not extending posteriorly to the superior constrictor muscle. So just remember, tumor invasion into the retromandibular raphe potentiates the spread in multiple directions into the buccal space and oropharynx. So retromolar trigone lesion, depending upon the position, it can involve the mandible if it is lower down, or the maxillary sinus if it is upper, and it can involve the inferior alveolar nerve or the superior alveolar nerve, and also buccinator and superior constrictor muscles. And now, I think now the retromolar trigone space is clear. And now coming to the sublingual space. Sublingual space, so the space inferior to tongue. So various structures are seen, and some structures we have already seen, like lingual septum. So in the center, I am seeing the lingual septum, and the lingual septum in the MRI it is seen hyperintense because fat is there. That is why it is seen hyperintense, whereas in CT it will be dark because of the fat. And this, now everybody is familiar with this thing, lingual septum, where to look for lingual septum in the midline, exactly in the midline. And now lateral to that, the genioglossus muscle, that also you already discussed about that genioglossus muscle. And further lateral, we can see the hyoglossus muscle. So these three structures are now clear. Lingual septum, genioglossus muscle, and hyoglossus muscle, which are the extrinsic muscles of the tongue. These two muscles are the extrinsic muscles of the tongue. And now I am seeing a space further lateral to genioglossus muscle. This space. So this is actually hyperintense. So that means this contains fat, and this is the sublingual space. So you can see the sublingual space here. Sublingual space here. So that is the lateral to genioglossus muscle. And the sublingual space, it is seen underneath the tongue. And we will see further in the coming session, in the coming slides. And one more space here, further lateral. Here again, hyperintense area, so the fat. This is just within the mandible, within the mandibular inside cortex. So what is that? Just remember, this is not sublingual space, this is submandibular space. So how submandibular space comes here, we will come to know later. Okay. So sublingual space, submandibular space, in between you are seeing one muscle. This muscle. So what is this muscle? Actually, this muscle forms part of floor of mouth. This is mylohyoid muscle. This is mylohyoid muscle. So genioglossus, hyoglossus, and the third muscle here seen, that is the mylohyoid muscle. Mylohyoid muscle. Now you know where to look for the sublingual space. And just remember, this is submandibular space. Submandibular space. In the coronal, so this is sublingual space. Sorry, this is sublingual space, and this is muscle. So genioglossus muscle. So genioglossus muscle, and here you are seeing one more muscle, that is the geniohyoid muscle. Inferior to the genioglossus, geniohyoid muscle, and the geniohyoid muscle again, it is from the genial tubercle, that is from the lower genial tubercle to the hyoid bone. The genioglossus, it is from the upper genial tubercle or ventral spine, upper, and the geniohyoid is from the lower And you may be remembering that part of the genioglossus muscle is going to the hyoid, and inferior to the genioglossus muscle, you can see the geniohyoid muscle. So this is geniohyoid, and this geniohyoid muscle, genioglossus muscle, and the lingual septum form the root of the tongue. So this is the root of the tongue, the root of tongue. And lateral to the root of tongue, you are seeing the sublingual space. So this is sublingual space. And one more muscle I am seeing here, mylohyoid. This is the mylohyoid muscle. One more muscle I am seeing here, that is the digastric muscle, anterior belly of digastric muscle. So anterior belly of digastric muscle, mylohyoid muscle, and the geniohyoid muscle, they are nothing to do with the tongue. And these three muscles form the floor of mouth, or these are floor of mouth muscles. Okay. And here, this is the mylohyoid muscle. It is a sling-like muscle. It is originating from the mylohyoid ridge inside the mandible, and it is attaching to the other side of the mylohyoid ridge. So it is a sling-like muscle. And inferior to that, you can see the anterior belly of digastric muscle. And this is the geniohyoid muscle and genioglossus muscle. I hope now it is clear. And in the sublingual space, so genioglossus muscle, hyoglossus muscle, and this is the sublingual space. And here you can see the sublingual space. The sublingual space, what are the contents of the sublingual space? You can see the artery, lingual vein, and also the lingual nerve. So these are the main contents of the sublingual space. And also part of the fibers of the hyoglossus muscle are in the sublingual space. And then another structure is the Wharton's duct, which is coming from the submandibular gland. That is also there in the sublingual space. So these are the main contents of the sublingual space. And the mylohyoids we just discussed. And this is the mylohyoid muscle. And this is what we saw earlier. So there is space inside the mandible, just inside the mandible. Some people take this as the submandibular space. Actually, this is not submandibular space. And this is, of course, the space contains fat. That is why in CT it is dark. So what is the space? You know, this is submandibular space. We already discussed about that. This is submandibular space. Then why submandibular space comes here, or how does it come here? See here, you can see the submandibular space here, and here, see, this is submandibular space, and here you can see some nodes in the submandibular region, and these nodes are displacing the mylohyoid muscle inwards. Okay. And the next section, caudal section, the caudal section, you can see the submandibular nodes here. So submandibular nodes which are extending up inside the mandibular arch, and they are displacing the mylohyoid muscle inwards. So actually this is nothing but extension of the submandibular space upwards inside the mandibular arch. So the lateralmost, the fatty area is the submandibular space only. And this is, you can see how beautifully the structures are seen in MR. So that is why when comparing with the CT and MR gives beautiful images. So it gives better delineation. So the hyoglossus muscle, mylohyoid muscle, submandibular space, sublingual space, the lingual septum, genioglossus muscle. Okay, everything is seen beautifully in coronal also. And the submandibular gland, here you can see the submandibular gland, and here is the submandibular gland and myloid muscle. You know that submandibular gland has got superficial lobe as well as deep lobe, and part of the submandibular gland is arching over the posterior ridge of the mylohyoid muscle, and it reaches the sublingual space above. Okay, so here we can see part of the submandibular gland. So sublingual space, please remember sublingual space and submandibular space. The structures and all, apart from the lingual nerve, artery and vein, you can see glossopharyngeal and hypoglossal nerves. The structures, actually this is important because if lesion is there, there can be perineural spread. So this can spread along the lingual nerve to higher levels. So here you can see enhancing mass, poorly defined mass in the floor of mouth, and there is destruction of the adjacent mandible. And in the coronal, you can see the lesion here with the destruction. And once you know the structure, the anatomy, you can then easily identify which all structures are involved and which all structures are not involved. So here one is definite that this lesion is not crossing the midline, because I can see the lingual septum beautifully, I can see the genioglossus muscle beautifully. Okay, so this is not crossing. Probably the hyoglossal muscle. So the hyoglossous muscle you can see here. Here I am not seeing. So hyoglossous muscle is probably infiltrated by this mass. And of course, the mylohyoid muscle here, that is also infiltrated. And the submandibular space, of course, there is involvement of the submandibular space. Okay. So once you know the anatomy, then you can say the extent of the lesion. You can assess the extent of the lesion in a better way. And coming to the mucosal space, mucosa, it involves only the mucosa. So mucosal lining, wherever mucosa is there. So actually that involves the mucosal space involves all these mucosa. So over the lip, over the alveolar process, or in the retromolar trigone, in the buccal mucosa, along the floor of mouth, or the hard palate, or over the tongue. So all these are mucosal, or it comes under mucosal space. And coming to buccal space, so buccal space, cheek, the contents are, one is buccal mucosa, second is muscle buccinator, and external to the buccinator is the buccal pad of fat and further lateral skin. So here in the CT, the puff of cheek, when the vestibule is distended, you can see the buccal space in a nice way. So this is the mucosa, and this soft tissue strand, that is the muscle, buccinator muscle, and lateral to that we can see the buccal part of fat, lateral most is the skin. So these are the structures of buccal space. Or some people call it as BUCCO-MASSETERIC space. BUCCO-MASSETERIC space, because along with the buccinator, the space contains the masseter muscle posteriorly. We know the masseter muscle is seen along the outer surface of the ramus of mandible. So this is the masseter muscle, and further posterior we can see the parotid gland. Part of the parotid gland is seen encroaching onto the posterior part of the masseter muscle. So including both buccinator and the masseter, it's called BUCCO-MASSETERIC space. And in the BUCCO-MASSETERIC space, if you look carefully, you can see one strand-like thing, lesion, or not lesion actually, it is a structure. So this is nothing but parotid duct. So the superficial lobe of the parotid gland, the parotid duct or Stensen's duct starts from here. It courses over the masseter muscle, superficial to the masseter muscle. It reaches the anterior border of the masseter muscle, and there actually it curves medially. It curves medially and pierces the buccinator muscle, and then the mucosa, and it opens into the vestibule opposite to the upper second molar tooth. So this is the parotid duct. So you are seeing fat anterior to the parotid duct as well as posterior to the parotid duct. Okay. And one more structure you are seeing, sometimes it can be mistaken for a lesion. That is why I am saying this. So there is a soft tissue strand-like thing over the zygomaticus muscle, and then you are seeing this. This is zygomaticus major muscle. So this should not be mistaken for a muscle. So this is the muscle that you are seeing within the buccal part of fat. Okay. Then the last part, just because as far as the lesions are concerned, the malignancy is concerned, especially with, it can happen with squamous cell carcinoma, but especially with adenoid cystic carcinoma or mycophthalmic carcinoma, the perineural spread is notorious. So if a lesion is involving some part of the oral cavity, and you should know which nerve is likely to get involved, and also you should be able to follow that nerve up to its origin to exclude or to rule out perineural spread. So the perineural spread, unless otherwise carefully looked for, you are going to miss it. And also the treatment plan will vary definitely when perineural spread is there. So some important nerves in relation to the oral cavity, we will just discuss about that. And the mandibular nerve, one division of the mandibular nerve, lingual nerve, we have already discussed that the lingual nerve will be seen in the sublingual space. Okay. Okay. So when tongue is involved or when the floor of mouth is involved, there is likelihood of lingual nerve is also infiltrated. Once the lingual nerve is infiltrated or involved, so there can be spread along the lingual nerve up. So where should I look for the perineural spread of lingual nerve? For that, you should know the root of lingual nerve. So you know the lingual nerve arises from the mandibular nerve. Okay. And the mandibular nerve, the skull base, first it lies between the tensor palatini muscle and the lateral pterygoid muscle. Tensor palatini muscle and the lateral pterygoid. And after that, it is seen between the lateral pterygoid and the medial pterygoid muscle. And lower down, it is seen between the medial pterygoid and the ramus of mandible. Okay. Then, see, this is the lingual nerve. It's coming like this and reaches here. And after that, it curves medially and anteriorly, and it winds around the submandibular duct, and it supplies the tongue. So here it is seen in the sublingual space. So the spaces where to look for the lingual nerve involvement. One is, again, before that, just I will mention about this also, inferior alveolar nerve. So inferior alveolar nerve, again, it is division of mandibular nerve, and it is seen lateral to the medial pterygoid muscle. Lateral to the medial pterygoid muscle. And it is seen between the medial pterygoid muscle and again the ramus of mandible. Okay, inferior alveolar nerve. So almost similar course. So where should I look for this lingual nerve and inferior alveolar nerve? So lingual nerve, first I told, it is seen between the tensor palatini and the lateral pterygoid. So where is tensor palatini? It is a very slender muscle. It's a very thin muscle, difficult to see. So what I can say is, just you can see this is the level of nasopharynx. You can see the torus tuberous here. This is the eustachian tube opening. This is the fossa of Rosenmuller, nasopharynx. So the tensor palatini, it runs along the outer side of the superior constrictor muscle. So that means it will be seen somewhere here. That much only I can say. So I have to look for somewhere between the superior constrictor muscle here and the lateral pterygoid muscle. So superiorly, just below the skull, you can see the lateral pterygoid. So I have to look for the lingual nerve and the inferior alveolar nerve here in this space. Just remember, lateral to the wall of the nasopharynx. Okay. And further down, I have to look for this area. So that is between the lateral pterygoid and the medial pterygoid muscle here. Initially, between the wall of the nasopharynx and the lateral pterygoid, 2 centimeters down, I have to look for between lateral pterygoid and the medial pterygoid. Further down, I have to look for between the medial pterygoid. This is the insertion of the medial pterygoid to the ramus of mandible. So between the medial pterygoid and the ramus here, both lingual and the inferior alveolar nerve. Okay, and lingual nerve then further courses anteriorly and goes medially and reaches the sublingual space, whereas the inferior alveolar nerve enters the mandibular foramen here. Mandibular foramen here. The coronal, you can see the mandibular foramen here. And further down, actually it courses along the mandibular canal and it comes out, inferior alveolar nerve comes out here through the ventral foramen, and it supplies here subcutaneously. So this is the root of the inferior alveolar nerve. So here we are seeing a lesion in the lower gingiva. There is destruction. Alveolar process destruction is there. Also the body of the mandible is destroyed. So there is likelihood of lingual nerve getting involved. Sorry, not lingual nerve, inferior alveolar nerve getting involved. So I have to look for the mandibular foramen here. So you can see the mandibular foramen here is widened and there is soft tissue dense area. So this is nothing but thickened nerve. Normally you won't see this much thickness in nerve. So thickened nerve, and also it is enhancing. So I have to suspect perineural spread along the inferior alveolar nerve. And the last part, that is the palatine nerves. Palatine nerves, pterygo-palatine ganglion, maxillary nerve, foramen rotundum. See, here is the pterygo-palatine ganglion. So that lies in the pterygo-palatine fossa. And you can see the greater palatine nerves and the lesser palatine nerves. And it reaches the pterygo-palatine fossa. And from there is attachment to the maxillary nerve here, the superior part of the pterygo-palatine fossa. And the maxillary nerve reaches here through the foramen rotundum. From the middle cranial fossa to the foramen rotundum. Through the foramen rotundum, it reaches the pterygo-palatine fossa. And the maxillary nerve continues as superior alveolar nerve. Superior alveolar nerve. Okay. So a lesion in the upper alveolar process can involve the superior alveolar nerve. It can reach the pterygo-palatine ganglion. It can reach the pterygo-palatine fossa. From there, through the maxillary nerve, it can reach the middle cranial fossa. Or hard palate lesion or soft palate lesion along the palatine nerves, it can reach the again pterygo-palatine fossa. From there, through the maxillary nerve, it can reach the middle cranial fossa. So this is one classical route of spread. So where should I look for again? So these are the palatine foramina. Palatine foramina, these are seen in the horizontal plate of the palatine bone. And this is the pterygo-palatine fossa. Pterygo-palatine fossa. And here I am seeing a canal and opening here, and this is the foramen rotundum. So this is the middle cranial fossa. This is the root of the maxillary nerve. So just see the relationship. The pterygo-palatine fossa, posteriorly the foramen rotundum, middle cranial fossa. And further up, you can see the pterygomaxillary fissure here. So pterygomaxillary fissure is actually between the base of the pterygoid plates, and the posterior wall of the maxillary sinus. So you have to look for the pterygo-palatine fossa here. Sometimes it will be a very narrow space, very potential space, very thin slit-like space only you can appreciate. Anyway, here the space is little widened. So that is why you are able to see the pterygo-palatine fossa. And here this is the pterygomaxillary fissure here. Okay. Anyway, the pterygo-palatine fossa, and further up you can see that this is continuing as inferior orbital fissure, and reaches the orbital cavity. So all these are connected: inferior orbital fissure, pterygo-palatine fossa, foramen rotundum, middle cranial fossa, and the greater palatine and lesser palatine foramina. So here, lesion in the hard palate, enhancing lesion in the hard palate. So that can very well involve there is very high chance of involvement of the palatine nerves. So I have to look for the pterygo-palatine fossa. So this is the pterygo-palatine fossa, and here the pterygo-palatine fossa is widened, and there is a soft tissue structure which is enhancing. So I have to suspect perineal spread. So perineal spread, and here posteriorly I can see the foramen rotundum and the canal that is also seen as little widened. Because why I am seeing this is widened? Because I can compare with the opposite side. So this is the foramen rotundum here, and on the opposite this is the foramen rotundum. Okay, so this is widened, and some enhancing structure is there inside. And the pterygo-palatine fossa here, and this is the bone window, and the widening of the foramen rotundum here. And in the MRI, you can see the same lesion, hard palate lesion. And here, this is actually contrast image, T1 weighted contrast image. You are seeing enhancing lesion in the pterygo-palatine fossa. And this pterygo-palatine lesion is extending to the inferior orbital fissure, and posteriorly through the foramen rotundum and the canal, it's reaching the paracellar region. It is reaching the cavernous sinus. So this is how you have to look for the perineural spread. So if you know the root of the nerve, you can look for the spaces or the corresponding spaces, and see whether any abnormal enhancement or soft tissue mass is there. Then you have to and also lingual nerve, and also we already discussed about the lingual inferior alveolar nerve and lingual nerve, and we reached right up to the skull base. That is, from there actually the nerves, lingual nerve and the inferior alveolar nerve start, and from there again you can trace the mandibular nerve through the foramen ovale to the middle cranial fossa. So like that you can trace the nerves, you can chase the nerves, and you can reach the target or the destiny. Okay, thank you very much.
Thank you, sir. Thank you so much. It was indeed a very elaborate and very nicely explained and cleared many concepts. So, sir, should we go for the next session now, or should we take the questions now?
We will take the questions now. Okay. Tensor need not
Okay.
wait for. Yeah. Any questions? Then we'll go to the next session.
Sure. So if there are any questions, please you can use the chat box, or also you can unmute. Sir, there are few questions on YouTube also, as we are live on YouTube. So I'll just read them out. Sir, there is a question by Dr. Vinayak Subramaniam on YouTube. He's asking how to differentiate between a mucosa and muscle. I think he asked
Yeah.
during
The buccal space, no? The buccal space. Buccinator muscle, no?
Okay, sir. Yes. Sir.
Yeah. Actually,
Sir,
it's a good question. When somebody is showing something, no, actually you cannot see what is the difference between the mucosa, because it's only a very thin structure. Okay, and muscle is lying close to the mucosa, and it's very difficult to differentiate between mucosa and muscle. So what is seen as soft tissue density, has to be taken as muscle, buccinator muscle, and the medial side of the buccinator muscle, okay, medial side or the inner side of the buccinator muscle can be taken as mucosa. That's all.
okay, sir.
Is it clear? Yeah.
Yes. Then Dr. Jagrit is asking, sir, please explain retromolar trigone once again. And Dr. Divya is asking.
No, actually, this can be seen again. No, this can be. I don't have to repeat it because this will be there in the YouTube. So at any time, whenever you get time, you can just through the link. Actually, you can see this. So I don't have to repeat it.
Okay.
Is it
so,
okay?
Dr. Divya is yes. Dr. Divya is asking, can you please show masticator space on CT?
No, initially I told no, because actually this is out of the purview of this talk. That is why I specifically I excluded masticator space. You may be remembering that when in the first slide itself, I showed that I am not going or touching anything posterior to the or out what do you call hard palate, posterior border of hard palate now. Only to show the perineal spread, I reached there. Actually, this actually we can discuss in another session now. The masticator space and all, masticator space, parapharyngeal space, the carotid space, visceral space, parotid space. It's a very big topic, and I think time won't permit. Sorry.
Okay, sir. Okay. So, are there any more questions?
Okay, thank you very much.
Sure, sir.
Thank you.
Thank you.
Thank you.
So much. So now we will be having the second session on the management overview of CA oral cavity by Dr. Cecil Thomas Kainickal. Sir is additional professor in head and neck oncology in Regional Cancer Center, Trivandrum. Over to you, sir.
Yes, give me 1 minute. Let me share the screen. Can you see my screen?
No, sir, the screen is not visible.
Okay, wait. Give me 1 minute. Okay. Can you see the screen now?
Yes, sir, it's visible.
Yeah. So, after an excellent radiology session, I'm sure you learned a lot from Rama. Sir, so he's an excellent teacher. If you have any queries, you can direct your queries to him personally. I will give his email ID. Or you can send your queries to me. I will direct the questions to him. So after the excellent radiology lecture, so we will be discussing the management of oral cancer. It's a big topic. So I want to finish the whole lecture by say 30 minutes, because we will wind up by 30 minutes, and after that we will take up some questions, because you will benefit more from question and answer sessions. So we know that this is a very global problem. This is also a very major health problem in our country. And the main difference between the Western population and Indian population is that most of the tumors we come across in Western population is tongue and floor of mouth in Western population. And in India, we come across a substantial portion is gingival complex tumors. And the main difference between these two are the tongue is more aggressive. They have a high lymphatic supply. And the gingival complex tumors are mainly indolent tumors. They are mostly well differentiated tumors compared to tongue tumors. And lymphatic spread is also less compared to tongue tumors. And if you treat a tongue tumor, most of the relapse occurs in the neck. But if you treat a gingival complex tumors, most of the relapse occurs in the primary site than the neck lymph node. Another difference is that most of the lymphatic spread from gingival complex tumors usually occurs to only one B node, submandibular node. You do not come across a level 2 node unless it is from the 1B range to level 2. You usually do not come across a level 2 node from a gingival complex tumor. But the posterior 1/3 of the anterior 2/3 of the tongue drains directly to level 2 lymph node. So you can bypass 1B and you can have level 2 lymph node in a tongue tumor. So it's a different biology, but if for a Western population, this is the same malignancy because the gingival complex tumors are very low and they consider the tongue and floor of mouth as the oral cavity. But in Indian context, we should not consider this as the same disease because many of the gingival complex tumors can be treated by radiotherapy or chemoradiation, selected tumors. So you should not extrapolate this to the Western population and consider as a single disease. That's one important thing I want to make before my presentation. So I'm coming from Kerala in a state where there is 100% literacy. But in Kerala, the substantial oral cavity, the oral cancer presents an advanced disease. We come across 30 to 40% as early disease, but 50 to 60% as advanced disease, stage 3 and stage 4. As there is a stage migration from early disease to advanced disease, you know that the patient will have a poor outcome. So if you have an early disease, it's like this, a T1 tongue. So you have a disease in the anterior 2/3 of the tongue, a T1 disease without an oral involvement, or a lip lesion. This is a T1, but T2 disease, they are considered early disease. So what is early disease? Early disease is stage 1 and stage 2. That is early disease. So a T1N0 or a T2N0 is considered stage 1 disease. And the patient should not have a lymph node involvement. If you have a 1B lymph node and it is clinically relevant, you are dealing with a stage 3 disease. And the prognosis is poor and survival comes down drastically. This is one of the important things. So how to treat the early disease? Early disease, if you have a stage 1 or a stage 2 disease, the stage 1 disease survival is 80 to 90%. The stage 2 disease 70 to 80%. That is the 5-year survival. So main concern in this group of patients, the survival is more or less plateau. One is to have a good cure the aim is to have a good local control. Second is to minimize the morbidity due to treatment in our disease, to preserve the function. This is the main goal. So you have to have good local control, preserve the function, and minimize the morbidity due to treatment. And which modality is going to have a good functional outcome for these patients? So There is no randomized data of radiotherapy-based surgery in early oral cancer. All are retrospective. So we have to take the wise decision for this particular patient in early disease. So you should not compromise on local control, but at the same time you should have a good functional outcome. So this T1 and this early lip disease. So early disease is T1 and T2 disease. It's a clinically staged disease. So you usually do not need any extensive imaging in early disease because it's a clinically staged disease. You should restrict the treatment to single modality. That is radiotherapy or surgery. The aim is to have a cure with a good functional outcome. And second goal is to reduce the morbidity. How to decide between radiotherapy and surgery in early disease? These are the four important factors you need to consider. One, the functional outcome, whether radiotherapy is going to have a better functional outcome. Number two, which is the expertise available for these, whether for brachytherapy, for a surgery. Third is which is going to give the morbidity. And fourth, which is the patient. The decision for an early oral cancer cannot be taken in a human body. The decision should be based on the factors. And the patient is the key, and patient should take the call whether the patient should undergo radiotherapy or surgery. So for a patient, which we have seen earlier, that's a T1 tongue lesion. So how to select? These two options can be here for a T1 and 0 tongue. We will take few case scenarios. The T1 and 0 anterior to the tongue. So you can have, the patient can have one, you can have brachytherapy. Selection criteria should be very good. Why? Because I said this aim is to have a cure. Number two, most of the tongue tumors relapse in the neck. Okay, for a T1 tongue, the chance of lymph node involvement is around 10 to 15%. So proper selection is very important. Ensure that you are dealing with only T1 tongue. Number two, it should not be T2. Second thing, the patient should have a well-differentiated histology. All patients should have an ultrasound. Then ultrasound is the best investigation to look for an N0, evaluate the N0 neck. Should be a T1 disease, superficial lesions, and patient should be ready for regular follow-up. Why? If you do a brachytherapy, you are not addressing the neck. So the patient can have a nodal relapse, and then we may lose, the patient may come back with an inoperable nodal relapse. So to start with, it is a stage 1 disease, and it will end up in a palliative setting. So that is very important. This is very important for a early tongue tumors. So proper patient selection should be there, and patient should be counseled that what is the pattern of relapse if you do not treat the neck. So this has to be properly counseled when you take the patient for, and this is applicable for lip as well. If you take the patient for a brachytherapy. And you can have a LTR brachytherapy or an HTR brachytherapy. Most of the centers now prefer an HTR brachytherapy. And this is a 65 to 70 gray biologically equivalent dose to around 45 to 60 gray. So generally you use in our institution, we use a 4 gray BID schedule. That is 8 gray into 6 days. So from Monday to Saturday, 48 gray in 12 fractions over 6 days. That is 4 gray BID, 4 gray in the morning, 4 gray in the evening, and for 6 days. The most important thing is that the follow-up after brachytherapy. The patient should be properly counseled. Okay, suppose a middle-aged man walking in, a patient with middle-aged with a T1 tongue or a T1 lip or a early superficial T2 lip. Generally, the neck should be treated rather than leaving the patient with brachy alone, because the patient will not come back for close follow-up. So we may lose the patient. So most important thing is this patient should have expertise to do that. Number two, the patient should have a proper selection. Third thing is that patient should be ready for close follow-up. And if you look into the various, all authors have shown that in selected patients for lip lesions as well as for tongue, the 5-year local control ranges from around 95% to 100%, 95% to 98%, and 10-year is around 90%. So in good hands, this have good outcomes in brachytherapy. And you can read this paper. This is published in Green Journal in 2009. That is in Green Journal. That is Jekes recommendations for brachytherapy or head and neck squamous cell carcinomas. So you can go through this paper. So I will take, so for a T1N0 tongue, you have two options. Either you can have brachytherapy or you can consider surgery. Surgery is you have to do a wide excision plus you have to address the neck T1N0. Then for a T2 disease, the T2 disease, I'm taking a case for a buccal mucosa and I will case a discuss for tongue tumor. So it's a T2 buccal mucosa. So it's a verrucous lesion. So both are T2s. Here, both upper and lower TB sulcus is involved. It's very close coming to the anterior commission. And this can be treated by two modalities, radiotherapy and surgery. So in radiotherapy in exophytic lesions, these patients can have radiotherapy or surgery. In these tumors, you have to address the neck also. Either can you have an external beam radiotherapy as your sole treatment, or you can consider external beam radiotherapy plus a brachy boost, because the node has to be treated. So in this group of patients, I prefer radiotherapy rather than surgery. It's a personal bias. There is no data comparing this two because this will have a good local control. But if it is an infiltrating disease, I prefer surgery. But exophytic lesions for a T2 buccal mucosa, you can have two options. Either you can have radiotherapy. Radiotherapy gives excellent locoregional control, good functional outcome, especially for tumors very close to the lip. And you can have wide excision plus a supraomohyoid dissection plus bar minus reconstruction if required. For a T2 buccal mucosa, both options should be given to the patient, especially for exophytic tumors. In Kerala, we come across mainly the ulcer proliferative disease. Mainly this is because of the arachnet and beetle nut. Most of them are proliferative tumors. So that is one of the reasons we prefer to give radiation for these patients. And so this patient should be offered both options. And the patient should decide whether the patient should undergo radiotherapy or the patient should undergo surgery. So that is T2 buccal mucosa. This is one of the patients, one of my patients who received radiotherapy coming for follow-up. We may be even able to make out the patient has received. The patient has received a accelerated radiotherapy 5-50-15. And recently we have done audit of the patients who have received this 5-50-15 for the last 10 years. We have 517 patients received radical radiotherapy for this with this schedule. And we are evaluating the results, and the most probably will publish this data very soon. That is T2 buccal mucosa. Now we are coming to the tongue tumors. It's entirely different arena. I won't consider, I'm not a good fan of radiotherapy for tongue tumors. It should be treated surgically. Okay, so I'm saying unbiased because in buccal mucosa, in exophytic tumors, I prefer radiotherapy. Although two options are there, radiotherapy and surgery. For tongue, I have T2 tongue. I have only one option, that is surgery plus bar minus surgery. This you have to consider, it's a wide excision. You have to very properly examine the patient, and the patient should have how many centimeters from the tip, what is the tumor size, extending into the ventral surface, extending into the floor of mouth, dorsally, whether it is how many centimeters from the midline or whether it is crossing the midline, what about the posterior extent, what about the mobility of the tongue, any lymph nodes. These are all important when you evaluate a T2 tongue. So if the patient is having good performance status and patient is less than 70 years, the intentionist treatment is to consider wide excision plus a supraomohyoid dissection plus bar minus reconstruction for this patient. And never consider brachytherapy or never consider external radiotherapy for this patient. The patient should undergo surgery. So if a patient is, say, above 70 years, or patient is having a performance status 2, because it's a thick lesion. So whether you will consider the patient for surgery, it needs discussion because there is no evidence. So all the guidelines for the treatment is up to 70 years and patients who have performance status 1. If it is performance status 2 or the patient is elderly, then you have to negotiate. You should have a discussion with the family. What are the expectations, the morbidity? And if the patient requires post-op radiation, what is the compliance? These all things have to be planned before subjecting that patient for surgery, even if it is an early disease. So it has three components when you discuss the surgical management of an early oral cancer. One, the treatment of the primary disease. You should have an en bloc removal of the primary tumor. Clinically, you should have a clearance of 1 centimeter. Pathologically, you should have a clearance of 0.5 centimeters. And Beyond 0.5 centimeter, pathologically it is considered as margin is negative. And all patients, suppose if a patient is having a T2 disease, the chance of lymph node involvement is around 30% for a tongue tumor. And if it is, so this patient should have a selective neck dissection, 1 to level 3 clearance. Generally, T1 and T2 do not need a reconstruction. You can do a primary occlusion, but if there's sometimes you may require a reconstruction. So that is early disease. So this is a T1 and a T2 disease. This is then you consider reconstruction. So I have some questions. I will take up the questions at the end of the early disease. Then we will go to the advanced disease. So you have the next question. Next is, so why you do consider a supraomohyoid neck dissection T1 and T2? For a T1, it is around 15%. For a T2, it is around 30%. So that is the lymph node involvement we have to run. And moreover, there is a randomized trial from Tata Memorial Hospital comparing a selective neck dissection for a therapeutic neck dissection in patients with early oral cancer. It was found that the patient who received an elective neck dissection had a better survival, 3-year disease-free survival and overall survival compared to patients who underwent neck dissection and the patient had a nodal relapse. So in patients who received elective neck dissection, had a disease-free survival, and it's almost, you can see the 3-year disease-free survival was 69.5% in patients who received elective neck dissection, compared to 45.9% who received a therapeutic neck dissection. And same is almost a 15% improvement in overall survival, and there is a dramatic reduction in death. The hazard ratio of death was 0.64. There is a 36% relative reduction in death in patients who received elective neck dissection compared to a therapeutic neck dissection in early oral cancer patients. And substantial number of patients were tongue tumors in this paper, and published in New England Journal of Medicine 2015, and presented by Professor Anil De Cruz in ASCO annual meeting in the plenary session in 2015. Now, after surgery, the patient, you should have a checklist. The patient should have a tumor site. So where is the tumor? Where is the laterality, the tumor focality? Then what is the size of the tumor? The histological type, grade of the tumor. Then what about the margins? Then the lymphovascular invasion, perineural invasion, worst pattern of invasion, because this is gaining more popularity nowadays, although there is no data to say that this will have an impact in deciding adjuvant treatment as of now, but clinical trials are underway. Then the lymph node involvement, how many nodes are positive? Then what about the extracapsular extent, which is the level of lymph node involvement? So all need to have a proper reporting before deciding the adjuvant. For a T2 and 0 clinical stage, which is the treatment decision is surgery plus bar minus adjuvant, because the depth of invasion or perineural invasion, lymphovascular involvement, or a node positivity can take a call for an adjuvant treatment. Suppose if this patient had a PT2 and 0, we have seen the case, and if the patient had a pathologically 2.5 into 2.5 centimeters, and nodes are negative, and there is no lymphovascular invasion, and depth of invasion is 0.6 centimeters, then this patient do not need an adjuvant treatment, and this patient requires only follow-up. And how you consider the depth of invasion? Depth of invasion is you find out how you find out the depth of invasion. Depth of invasion is find out. You first make out the normal basement membrane. In the normal basement membrane, you establish a horizon at the level of the basement membrane, and you take a vertical line from that to the area where you can see maximum depth of infiltration. So this is the plumb line, and this plumb line is constitute the depth of invasion. So this is the depth of invasion. This is different from tumor thickness. Tumor thickness will be from here, but depth of invasion is at the level of the basement, normal basement membrane. So this is it. So if a patient is having an exophytic tumor, the depth of invasion may be less. But if a patient is having an infiltrative type of tumors, then the depth of invasion may be more. So staging also changes according to that. So in patients who have PT2, T1 or a T2 disease, you have two options, either surgery or you can have radiotherapy. For a tongue tumors, you prefer surgery. Then if there is no adverse features, you keep the patient on follow-up. And when you keep the patient on follow-up, you should properly counsel the patient. How the patient, what are the relapse pattern of the patient? That has to be properly communicated. Because when you treat with surgery, wide excision plus a supraomohyoid neck dissection for a T2 tongue. And if it is PT2N0, the most commonly the chance of lymph node involvement, say a relapse in the lower neck or in the contralateral neck. So this has to be communicated to the patient. And if the patient develops any node or any swelling in the neck, the patient should have a report early. Otherwise, you can have 2 to 3 centimeters. You can have a follow-up for this group of patients. So this is my personal opinion about the early oral cancers. For a gingivobuccal complex tumors, T1 and 0, you can have, if it is or lip lesions, you can have brachytherapy, or you can consider external beam radiation. If it is not accessible, you can consider surgery also in this group of patients, T1 and 0. In T2 and 0, you can have external beam radiotherapy or external beam radiotherapy plus vacuum boost. Surgery is the second option. So this is gingivobuccal complex tumors. For a tongue, highly selected tongue, you can have brachytherapy. Otherwise, you should consider the patient for surgery. For T2, no radiotherapy. It is surgery plus bar minus. So this is the standard approach you should have in gingivobuccal complex tumor and tongue. And this treatment option should be offered to all patients. And we are the treatment physician, the patient who is seeing the patient for the first time. If he's a surgeon, you have to give the option of radiotherapy. Also discuss the option of radiotherapy. If I'm seeing the patient, and I have to discuss the option of surgery also for the patient. And the patient should decide the treatment rather than the decision. It should be an unbiased decision to treat. Now coming to the advanced disease. So I have few questions. So, okay, I will take it, then I will go to the advanced disease. So I will rush up the advanced disease because it's getting time. Yes, there is a recording because there's a YouTube link sent to you, so you can access at any time. So there's RMT. That's I think that question is not to me. Is there any role for NACT in buccal mucosa cancers? That I will discuss. I will discuss that when we discuss the advanced disease. There is no role for systemic therapy in early disease. Now we are discussing early disease. It is a business between radiotherapy and surgery. So there is no disease role for systemic therapy in advanced early disease. In advanced disease, I will take up the role of neoadjuvant chemotherapy. Yes, how we take up the close margin. Okay, that I will also discuss. Sir, preoperatively, can MRI give an idea of depth of invasion? Yes, MRI can give an idea of depth of invasion, but this depth of invasion is a pathological finding and it's not a radiological finding. It has to be very clear with you. You cannot make out the basement membrane using an MRI. Okay, even the proper clinical palpation can give you an idea that whether this patient is having a high depth of invasion. If you do not have a frozen facility for a T2 tongue, you have to use MRI. But if you have a frozen facility, then you are evaluating pathologically in the theater. So you do not need an MRI for an early tongue disease. But this is indicated in advanced disease. Now, if the patient requires, what are the indications for dose escalation beyond 60 degrees? That's not the topic now. We will take up that. Is there in a role for the use? The YouTube link is already given to you in this, or if not, then I can give you the lab link. Then post-op RT dose escalation. Is there any dose escalation in early disease with a dose escalation in patients with without adverse features or patients with adverse features? That I'll take up when I discuss the advanced. Now, if there are certain situations where in early disease to start with, it will end up pathologically stage 3 disease. So this is a clinical scenario. This patient can have a depth of invasion more than 1 centimeter. Actually, this patient had a PT3 disease. So it was a PT3 disease because the depth of invasion was more than 1 centimeter. So if the patient size is by T2 and if the depth of invasion is more than 1 centimeter, then it is automatically a stage 3 disease. That is a T3 disease. But if the size is more than 4 centimeters, suppose more than 4 centimeters, and depth of invasion is more than 1 centimeter, then it becomes a T4 disease. So that is a TNM staging. In T2 tongue, why surgery and adjuvants considered? Why not radiotherapy? In tongue tumors, because they came in a different manner, that's one of the reasons why we prefer surgery for a tongue. Buccal mucosa is a different game out. Now coming to the next question. So it is a T3 means T2 disease with when the depth of invasion is more than 1 centimeter. That becomes a T3. That is more than 4 centimeter or less than 1 centimeter. Or T2 disease, that is 2 to more 4 centimeter, and depth of invasion is more than 1 centimeter, becomes a T3. Or any T3, that is more than 4 centimeter, with the depth of invasion more than 1 centimeter, then it becomes T4A. So in early disease, I will give you another clinical scenario where if a patient is having early disease to start with, if the patient is having margin positive, tongue, the nodes are negative, no PNI, no LVSI, this is T2 disease, but the PDL margin is positive. In such tumors, the treatment is not adjuvant because you are violating a basic principle of the single modality treatment for an early disease. So I will always discuss with the surgeon, and if a revision is possible, then you do a revision surgery and keep the patient on follow-up rather than subjecting that patient for. But if the patient has undergone a surgery in a frozen guidance and still his margin is positive, that's a bad disease. Then I discuss the option to stop chemoradiation. Otherwise, you consider a revision surgery. And if it is an unplanned surgery, or if the patient has not undergone a frozen guidance, then it turned to be positive, then I prefer to have a revision surgery than giving a post-operative radiotherapy. Now I will take up the next clinical scenario. So if a T1 or a T2 disease after surgery, if the margin is positive, the NCCN says you revision, you do a re-resection if possible, rather than giving radiation. So this will have a bad disease because biologically it's inherent. Okay, if the patient is unwilling for revision surgery, is it okay to give radiotherapy? That's yes, you can consider. But if you cannot make out the margin, the patient is not willing, then you have to say to the patient that it is a early disease. But if you do revision surgery, and it was initially not under frozen guidance, if you can do a revision surgery, and then you can avoid radiotherapy. But if you do not have a frozen facility, if it may be a badly infiltrating tumor, again, that you can end up in a margin positive. That also has to be communicated to the patient. Then you can decide, you can call for a post-op. Then it should be a post-op chemoradiation because it's a margin positive disease. So then morbidity will be higher, then chance for relapse is high. But if you can do a revision surgery by any means in such situations, it may be better to avoid radiotherapy. Yes, we will take up the next scenario. Next is advanced disease. So in early disease, the intention is if you do not have an adverse fetus, I am not dealing into the PNI, the LVSI, and if I take up that, then I will not be able to finish the advanced disease. So if you have PNI, LVSI, you discuss the option of adjuvant radiotherapy. If you have margin positivity but no adverse features, you do revision surgery. Pathologically, if it is PT3, and then you have to consider adjuvant treatment. And if the patient is having a single node positive disease, and if it is a clinically, it is a T2N0, and if it ends up in a single node positive. So how you stage the disease? It's a stage. It's not a early disease. So single node positive disease is stage 3. That's one of the important things you have to bear in mind. Then, where this the lymph node involvement, whether it is 1P or level 2, whether what is the size of the involved lymph node, whether extracapsular extension is present or not, and if the patient, what is the extent of lymph node dissection done, and whether PNI or an LVSI. So these are the factors which you need to consider when you consider an adjuvant treatment. So, and also a gingival-buccal complex tumor where it is a primary tumor. So all these factors you need to consider when you decide the treatment. What is the evidence? There is no data pertaining to single node positive randomized to adjuvant radiotherapy or observation. There is no data. But if you look into the retrospective data, mainly from MT Anderson and MSKCC, which was published in 70s and 80s, have shown that. And there is a reduction in local recurrence in those patients who received adjuvant radiotherapy. That is one. Then, second, if you look into the National Cancer Database, if that was published in JAMA, otolaryngology in 2016, patients with oral cavity and oropharynx put together, it was found that if patient is in single node positive, there is a survival benefit. If you look in the SEER database, which was published in Cancer in 2008, they have shown that In patients with node positive disease, there is a survival benefit of 9% compared to patients who do not receive radiotherapy. But this was for all node positive patients. And when they did a subset analysis, it was found that for stage 3 and stage 4, the magnitude of benefit for adjuvant radiotherapy was similar. So stage 3 includes PT1N1, PT2N1, it includes PT3N1 in node positive disease. So if you ask me, what about the PT1N1? Is there any prospective? There is, again, and one of the retrospective data is there's a national cancer database which was presented in ASTRO annual meeting in 2019. To best of my knowledge, this paper has not been published. But it has found that in around 1900 patients, those patients had PT1N1 and PT2N1 were evaluated. So the inclusion criteria was that at least 18 nodes should be sampled. When they did the analysis, it was found that median follow-up was 5.9 years. And the 5-year overall survival for a PT2N1, the p-value was 0.03, and it was statistically significant. There's around 9% improvement in patients who received radiotherapy. There is an improvement in survival. So I argue for radiotherapy in a PT2N1 disease. For a PT1N1, in the subset analysis, there was no survival benefit. Okay, but the primary endpoint was overall survival. If you look into the prospective, if you look into the URTC trial 22931, comparing radiotherapy basis post-op chemo radiation adjuvant, all stage 3 patients were included. Single node positive patients were also included. Perineural invasion patients were included. Were randomized between adjuvant radiotherapy or chemo radiation. Okay, so it's a stage 3 disease. The data in 70s and 80s have shown there is an improvement in local control. The National Cancer Database and SEER data have shown that there is an improvement in survival. And these patients were candidates for a prospective trial which evaluates the role of radiation versus post-op chemo. For putting all this together, for a tongue tumor with a PT2N1, I say stage 3 disease, then I will consider radiotherapy for this patient. So there is no data to say that this will have a negative impact. There is data to say that there is a benefit. Okay, now we'll proceed to so what about the NCCN guidelines is there? If you look into the ASCO guidelines, which is published in JCO in 2018, show that in single node positive, we argue not for radiotherapy. But if you look into the NCCN guidelines, you can see that for a T1 or T2 disease, one node positive disease without adverse features, the consideration is to consider adjuvant radiotherapy. So there is again, so this is you consider adjuvant radiation for it. Now coming to advanced disease, like I have 3 cases for advanced disease. Okay, do you want me to continue or you want me to stop here? Because I will take another 15 minutes to discuss this. Yes, continue, sir. Okay, thank you very much. So I have 3 cases for a T2 advanced disease. That's one is a tongue tumor, very thick infiltrating type of disease. For it was actually it's a T2, but you know that the depth of invasion from the proper clinical examination, it's advanced disease. And this patient had 2 nodes, one in the 1B and also in the level 2 disease. So I clinically staged as T2N2 disease, although it may be pathologically T3 disease, but I cannot stage clinically T3 disease because I cannot see basement membrane by using my naked eyes or by an MRI. So I have to stage it as T2N2B. And this patient should undergo a wide excision as we discussed and should have an extended supraomohyoid neck dissection, ipsilateral. And the patient should have or a modified radical neck dissection. If it is crossing the midline, you should have a contralateral elective neck dissection as well, reconstruction, and a post-operative radiotherapy is the planned treatment. Second, you can have this a T3 disease and patient had an N2A disease. As N2A disease is a single node ipsilateral, and the patient is more than 3 centimeters, less than 6 centimeters, without features of extracapsular extension. Mobility should not be restricted. So this is a T2, and it is a T3 N2A. Again, it's a stage 4 disease. It's a planned treatment. In such tumors, when you approach the problem, you should have it's a planned treatment, so the patient should have enough reserve to undergo surgery and also the post-operative radiotherapy. And suppose if you have a 73-year-old man, 75-year-old man, or patient have performed status 2, then you have to think twice before considering surgery for this patient, because the 5-year survival for a stage 4 disease is 30 to 40%. So you have to start that from that survival results to consider surgery and radiation. Whether this patient will undergo, what will be the general condition of the patient after surgery, whether the patient will undergo postoperative radiotherapy, whether the patient will complete that, what about the family support, and then only you can have a good outcome in such group of patients. So it's a planned treatment. I have another clinical scenario, as the sir said. So this I will revise what he has said. So this is the genioglossus muscle. Then you have the mandible here. You have, this is the submandibular space. It's obliterated, and you have the disease is coming very close to the skin, and this is a gingival-buccal complex tumor. And you have two nodes here. So it is a T4 disease. Two nodes. One is 1B because this is a submandibular gland. Anterior to submandibular gland, that's 1B. And one node which is posterior submandibular gland, that's 2B node. So it's a CT4A N2B disease. And patient should have surgical treatment, because you should never consider marginal mandibulectomy for this group of patients once the cortex is infiltrated. You should have a segmental resection of the mandible. You should have a extended supramohyoid neck dissection or a modified radical neck dissection. Reconstruction of the bone, then followed by a postoperative period. This is a planned treatment. Again, you have to decide the treatment from the beginning. Now, coming to the treatment. In general, if you have a advanced head and neck cancers, you have two treatment options. In general, locally advanced head and neck squamous cell carcinoma. This is you can have radiotherapy plus systemic treatment. This is standard in oropharynx, stage 3 and stage 4 larynx and hypopharynx with the in-back cartilage. And for nasopharynx is a separate disease. In oral cavity, it is in majority will go for surgery. In selected advanced disease will go for chemoradiation, that I will discuss. Or larynx or hypopharynx with cartilage destruction, the patient should undergo surgery followed by post-operative. All these are planned treatment, all with lot of morbidity. Yes, when we discuss advanced disease, when we discuss early disease, we said reduce the morbidity. But in stage 3 and stage 4, morbidity is part of the treatment. It's not a free lunch. It is with lot of morbidity. And support is very important. So in these patients in oral cavity, which group of patients will go for systemic treatment plus radiotherapy? In which patient should undergo surgery followed by post-operative? We have a gingival-buccal complex tumor, T3 disease, N0 or N1, or a earlier disease with a N1 disease. You can consider the patient for a non-surgical treatment. Outcome will be more or less same. In the T4 disease, in gingival-buccal complex tumor, you have to be very judicious in taking the patient for a radical approach. The patient should have a low limb disease, and patient should have a skin involvement, preferably less than 1 centimeter. The patient should have a good exophytic nature of the tumor, also proliferative disease, minimal skin involvement, absence of bone. The patient should not have a level 2 bone, and patient should not have a large bone. In this group of patients, you may consider radical chemotherapy, but you have to be very judicious in taking the selection criteria. Otherwise, you will burn your fingers, there will be residual disease, salvage may not be possible, the patient will end up in palliation. So selection should be very good when you consider a gingival-buccal complex tumor. In tongue tumors, no doubt, or a patient with a bone involvement, skin with ulceration, or the patient with a tongue tumor advanced disease, all will go for surgery followed by post-operative. And it's a planned treatment. Now, so surgical treatment includes, again, wide excision. You should have an extended supramohyoid neck dissection, or you should have an MRNT from level 1 to level 5 clearance, and you should have a reconstruction, and then followed by a post-operative. And you can have two classifications are there for neck dissection. There's one is Medina classification, which was published in 1989. It is considered as comprehensive neck dissection and selective neck dissection. The comprehensive neck dissection includes a radical neck dissection, which was the standard earlier. Now we consider MRNT. MRNT means modified radical neck dissection. When we can preserve, so you can have a preserve the spinal accessory nerve, internal jugular vein, in sternocleidomastoid, both on muscle, the nerve, as well as the vein. It can be preserved. That is called the type 3 of the MRND based on Medina classification. That is called the functional neck dissection. The selective neck dissection is not subclassified in Medina classification, but it is subclassified in the Academy's classification. The Academy's classification, broadly, it is divided into 4 categories: the radical neck dissection, modified radical neck dissection, selective neck dissection, and the extended neck dissection. That is beyond, anything beyond. The selective neck dissection is the supraomohyoid neck dissection, which is done for oral cavity. The lateral neck dissection, that is includes level 2, 3, 4, that is mainly done for if you do a conservation laryngeal surgery for a supraglottis or hypopharyngeal tumors. And anterior compartment, we know that it is for mainly for the thyroid. The posterolateral, if you have a posterior skin tumors, melanoma, you think, or any tumors in the posterior compartment, the posterolateral type, selective neck dissection. So coming to the patient who had, I will take a few clinical scenarios, then we will discuss the adjuvant treatment. So if a patient is having a single node positive, it's N1, the size of the involved node is less than 6 centimeters, but the extracapsular extension is present. Then what is the stage of the disease and how will you plan the adjuvant? The stage of the disease, pathological stage. So either it is PT2N1, that is PT2N2A, it is PT2N2A, that is PT3N1. So it is actually, the depth of invasion is 1.2 centimeters. So it is a PT3 disease. Size-wise, it is a 2 into 2.5. So that is T2 with more than 1 centimeter. So it is a PT3. Single node positive, ipsilateral node, less than 3 centimeter, and if that is showing an extracapsular extension, that is stages N2A. So it is a PT3 N2A, and it is stage 4 disease. But this patient should be offered a post-op chemoradiation because the patient is having an extracapsular extension. Then the other 2 situations are any node more than 3 centimeter, and if there is extracapsular extension, or if multiple nodes are present irrespective of the size, and if any one of them is showing an extracapsular extension, then it becomes an N3. And it is irrespective of whether it is ipsilateral or for N2A to be considered as, it should be pathologically N2A, it is 3 to 6 centimeters, less than 6 centimeter, no extracapsular extension, it is N2A. But the same 3 to 6, if the patient is having extracapsular extension, it becomes N3B. Single node, less than 3 centimeter, no extracapsular extension is present, and if it is ipsilateral, it is also considered as an N2A. If it is a contralateral node, and it is 3 to 6 centimeter, less than 3 centimeter, and is having extracapsular extension, it is not N2A, it is N3B. So to consider it as, it should be an ipsilateral node with an extracapsular extension, and it should be less than 3 centimeter to consider as N2A. So it is ipsilateral node, less than 3 centimeter, extracapsular extension is present, it is N3. All other situations is 3 to 6 centimeter with extracapsular extension, or any node more than 6 centimeter, then it becomes this with extracapsular extension. Or a patient is having multiple nodes or contralateral node, then it is an N3. Now, adjuvant treatment, I will finish in one slide because I have no time, because adjuvant treatment in oral cancer itself is a big topic. So I cannot take up the whole thing in one small lecture, but I will discuss this few clinical scenarios. If you have any of the queries, just post in the chat box, then I will take up. You can do in the YouTube as well. I will take up that. So this is any role for neoadjuvant chemotherapy in operable disease. And if you look, is there any data to give chemotherapy before surgery if you are in patients with operable disease? There are 2 clinical trials and there is a meta-analysis evaluating this problem. The first paper was by Lisa Lescitra from Italy, published in JCO in 2003. It was randomized between surgery or the surgery plus bar minus adjuvant treatment basis induction chemo followed by the same treatment. Then in patients who have oral cancer disease. And the endpoint was whether the patient is having any benefit in terms of locoregional control, overall survival, or disease-free survival. The outcome, when published in 2003, there was no benefit in terms of overall survival or locoregional control. But there was a reduction, 20% reduction in mandibular resection in patients with oral cancer. So that was the conclusion. And the data was updated in Annals of Oncology with a 10-year follow-up in 2013. There is no difference in outcomes. Okay, so the conclusion is that from that trial, there is no improvement in locoregional control or overall survival, but there was a reduction in mandibular resection rates. Another paper published in JCO in China, and it was published in JCO in 2012. The trial was, you give 2 cycles of TPA followed by surgery and adjuvant treatment phases, surgery followed by adjuvant treatment. 2 cycles instead of 3 cycles. In the first trial, it was PF. The second trial, it was TPF. No difference in the outcome. There was a meta-analysis incorporating these 2 trials and few retrospective studies published in European Journal of Cancer in 2015. No difference in outcomes. But there was a trend towards improvement in survival in CM2 patients. But the number of patients were very low. So you cannot draw any conclusion. The data should be interpreted with caution because it was a subset analysis. So the conclusion is that there is no benefit for giving induction chemotherapy in operable disease. Okay, please close margin status. So if we have less than point, say I will take one question. The question is, please give comment on close margin status in early stage post-op time. If it is more than 0.5 centimeter, then it is 0.1 to 0.5 is close. Less than 0.1 or in margin is positive. Okay, so that is how we have to take. Then the second is the role of NACT in a inoperable disease. Inoperable disease, there is no prospective. There is retrospective showing that there is an improvement in resection rates. There's a 43% of the patients may undergo resection followed by post-op radiation. Patients who received surgery after induction chemotherapy in inoperable disease, the median survival was 19 months. In patients who did not receive surgery, median survival was 9 months. Retrospective data published in Oral Oncology in 2014 by Vijay Patil from PH. So that is role of NACT. There is no data really evaluating the role of induction chemotherapy in borderline resection. Actually, this is an area of research because in order to attain R1 to R0 or R2 to R0, then you may need an induction program. And generally, this group of patients undergo induction chemotherapy based on logistic reasons and to attain R0 resection. One, to attain R0 resection, to reduce the extent of resection rates, to increase the functional outcome, maybe due to logistic reasons, because there is a delay in getting a study. Now, second question is pre-op versus post-op. The pre-op versus post-op. You can see that the post-op is better than pre-op because the post-op is based on RTOG study, 7303 clinical trial comparing pre-op versus post-op. It has found that in those patients who received post-op had a better locoregional control. There's no difference in overall survival. Published in Red Journal in 1991. Median follow-up 10 years. The minimum dose or post-op dose. The initial data of post-operative radiotherapy started from UK and from MSKCC, published as a retrospective data. One paper published in Clinical Oncology in 1980s. There's another data from Fletcher. They found that if you give post-op radiation, there is reduction in recurrence. There is a paper which published in European Journal of Surgical Oncology from Attack. Is comparing pre-op basis, comparing surgery or surgery plus post-op radiation in oral cancer. There is an improvement in disease-free survival, around 30%. And this is paved way for considering post-op radiation. Now the question is, what is the dose? There was a trial by Peters, published in Red Journal, in 1993. It was a randomized trial for low-risk patients and high-risk patients. Low-risk patients were randomized to 3 arms initially, 54 grade, 57.6 grade, and to 63 grade. And high-risk patients were randomized to 63 grade or 68.4 grade. Initially, data was published in Red Journal in 1990, updated in Red Journal in 2017 with a long-term follow-up by Rosenthal. It is shown that, and in the low risk group, 54 gram was abandoned because the patients who received 54 gram had a higher recurrence rate. So the minimum dose was 57.6 based on the previous study, and the high risk it was 60. There was no point in escalating the low risk from 57.63 to 63 grade, or in high risk patients to escalating dose from 63 to 68.4. So for high risk it is 63 grade, and low risk minimum dose is 57.6 grade. The standard dose is 60 grade 30 fraction, because in the pre-op basis post-op the dose was received was 60 grade 30 fraction. In the Katak study it is also the post-op dose was 60 grade 30 fractions. So the standard dose is 60 grade 30 fraction. That became the backbone of subsequent clinical trials, and the minimum dose is 57.6 grade. Now I will take one question before proceeding. What should be the CTV volume of tongue? Okay, post-op nartera is this whole tongue. Okay, that is I'm coming to that. Okay, please wait. Now the overall treatment, the minimum dose we discussed, the overall treatment time, the whole business of surgery plus post-op radiation should be complete within 100 days. Again, the paper published in Head and Neck in 2002 by Rosenthal. It has found that if the patient did not complete within 100 days, there was a reduction in local recurrence, reduction in local control or increase in local recurrence. Is there a role for an altered fractionation? There was a phase 3 trial was conducted at Tata Memorial Hospital by Professor Sarpani-Lesker, presented in ASCO annual meeting in 2016 annual meeting. It was a 3-arm phase 3 trial. It is the OCAT clinical trial. It has included 900 patients. Patients were randomized into 56 to 60 grade in 6 fractions, or same dose of radiotherapy in 5 weeks, that is 6 fractions per week, or 56 to 60 grade plus weekly cisplatin 30 mg. The data with a median follow-up of 58 months presented did not show any impact either by adding chemotherapy or by using an altered fractionation. So again, there is no role for altered fractionation. The post-op chemoradiation. Which patient should be offered post-op chemoradiation? The post-op chemoradiation should be offered. There are 2 clinical trials evaluating such problem. One is the RTOG 9501, other is the URTC-2291, published in New England Journal of Medicine in the first week of May in 2000. Both published with a median follow-up of 3-year results were published. Both showed an improvement in disease-free survival. And the OTC trial showed an improvement in survival by 13% improvement, a 40% in patients who received radiotherapy, and it was 53% in patients who received post-op chemoradiation. There was difference in inclusion criteria, but both trials showed there is an almost double increase in grade 3 and grade 4 toxicity. Acute was high, and the dose of radiation was 60 green 30 fraction in the RTOG trial, in the boost of 6 green 3 fraction was optional. EOTC trial used a 54 green 27 fraction, followed by a 12 grade boost in patients' areas of margin positivity for extraction. Both used cisplatin 100 mg per liter once. So there are slight difference in the inclusion criteria. I'm not going into details because it's scarcity. They did a pooled analysis of these 2 trials and published in Head and Neck in 2005. It showed that only patients with margin positive or extracapsular extension benefited from post-op chemoradiation, and it was not even benefited in patients with multiple non-positive. The RTOG trial 9501 was updated in Red Journal in December issue 2012. Even in patients with more than 6 or more lymph nodes, there was no improvement either in disease-free survival or overall survival. So the conclusion is that the post-op chemoradiation should be restricted to patients with margin positive or extracapsular extension. Although there was a National Cancer Database data published in GCU in 2017, whether the multiple node positive patients should be offered post-op chemoradiation. Again, it needs a lot of, it needs research. That's my personal opinion, because it's with a lot of toxicity, especially in Indian population. And the authors themselves say that it needs more valid data to recommend an outside clinical trial. Now, whether cisplatin should be given once in 3 weeks or weekly. This was evaluated by paper, by TMH people, TMH, and by Professor Kumar Prakash, comparing post-op radiation, radiotherapy, chemoradiation. That is mainly if we evaluate 300 patients were randomized, and almost 100 patients, 140 patients, or 148 patients, 1 arm, both were receiving post-op dose. So I consider it as a post-op chemoradiation comparing 100 versus 30. It was found that in patients who received, this paper was published in JCO in April issue 2018. It's a very good editorial very good editorial, accompanying editorial, and comparing 100 versus 30. It was found that 2-year local control was better in patients who received 100 versus 30. There was almost a 15% increase in grade 3 toxicity. There was no difference either in a disease-free survival or overall survival, but local control was better in patients who received 3 weekly compared to weekly cisplatin. Now, regarding any role for targeted therapy in that case, that is in high risk and no patients with intermediate risk. In the middle case, patients who do not have margin positive or extracapsular extension. And there was clinical trials comparing lapatinib, concurrent chemoradiation versus concurrent chemoradiation versus concurrent chemoradiation plus concurrent and adjuvant lapatinib for 1 year. Presented in ASCO annual meeting in 2014 by Professor Kevin Harrod, published in JCO in the next year, showed no benefit. And same is with the nimacimab trial, initiated by the National Cancer Institute, Singapore, is an ongoing clinical trial evaluating the same issue. So there is no data. And there was RTOG-0234, that's a phase 2 trial. If you look into the phase 3 trial in intermediate risk patients, RTOG-0120 clinical trial, evaluating the role of the cetuximab in addition to radiotherapy in patients who do not have extracapsular extension or multiple node positive patients, or patients who have other adverse features were randomized to give a radiation or post-op chemoradiation. We may have some preliminary results in this year or next year. We may have to wait for 1 year or 2. And this is adjuvant chemotherapy. The McKenzie meta-analysis have shown that, published in 2009 in Green Journal, which have shown that the hazard ratio is 1.06. Means if you give adjuvant chemotherapy, it can have a negative impact. It is detrimental. You should not give adjuvant chemotherapy. So that is all about adjuvant treatment. Now I will take up the question. What is the CTV oleum? Okay, I can see the number of participants dropping from 100 to 60, 40% loss. Okay, but still we continue. Okay, yes. What could be the what would be the CTV oleum in tongue cancer? Post-op. Okay, use an IMRT. So there is some preliminary data for a partial oleum radiation for tongue, but we do not have any hardcore randomized data evaluating this problem. So if you give radiation for a breast conservation surgery, whether you give partial oleum radiation, highly selected patient, yeah, you can give, but the most data is for the whole breast. In the same way, the whole data, majority of the data is with the whole tongue. So as of now, I will be a little skeptical to consider partial oleum radiation in that setting. Yes, how we define borderline resectability? That's a very good question. I will take it after finishing my lecture. Yes, so I conclude what we have discussed regarding the adjuvant treatment. Pre-op is post-op is better, minimum dose is 57.6 gray, oral treatment time should be within 100 days, no role for operable disease. I will discuss what is borderline operable disease, no proven benefit of altered fractionation. Post-op chemoradiation should be restricted to the margin positive and patients who have extracapsular extension with very good performance status. And ideally, we have only data for giving a high dose cisplatin once in 3 weeks. That's the standard adjuvant chemotherapy along with radiation. No chemo alone business in head and neck cancer, because adjuvant treatment, the backbone is adjuvant radiotherapy. So it is the high dose cisplatin once in 3 weeks is the standard. Any role for target agents? No benefit. Adjuvant chemotherapy is detrimental. I want to emphasize post-op chemoradiation it should be restricted only patients with good performance status. Never consider post-op chemoradiation above 70 years. No data, you will land up in troubles, and you will receive few fractions of radiotherapy. Patient will receive few fractions of radiotherapy, one cyclosis plant. Yes. Yes. Could you please share the? Yes, I can share the slides because I have the slides and I have references because I do not discuss because it's due to scarcity of time. Okay, other slide. Now coming to patients who are candidates for palliation, then I will take up the borderline resectable disease because that have come up in the chat box. Now, if a patient who is a 76-year-old lady presents with a performance status 2, always you should play down for this group of patients, especially the question is whether this patient will benefit. This patient is having trismus, skin involvement is there, and this patient may have a T4A bar T4P disease. And if you consider this patient for surgery, followed by whether the patient will benefit with, and whether the patient will benefit from the aggressive approach, whether the patient will tolerate the adjuvant radiotherapy, and what is the expected survival benefit. So this has to be, and this patient may also know, like you can make out a node there. So it's a T4AN1 disease. So we have to be very cautious in such group of patients. Patient may benefit better from a metronomic chemotherapy. There's no evidence for this group of patients. And some patients who have, first I will start with unresectable disease. Extensive skin involvement, cutaneous nodules, any nodule with a trismus, or if a patient is having extensive skin involvement. And this patient should not be offered a radical approach. And this patient should not be subject to CT. The first question is whether there are clinical signs of inoperability. If clinical signs of inoperability, you should stop an aggressive approach then and there. And the patient should be offered a systemic approach. I will not consider palliative radiotherapy because this will aggravate the trismus. So I will consider metronomic palliative chemotherapy for this patient. Cost of one CT scan will be equivalent to lifetime effort. So I always urge my residents to have a proper clinical examination. Ensure that this is, if you consider that no cutaneous nodules, no extensive skin involvement, this may be due to masseter or a medial pterygoid involvement, maybe an infra-notch disease. The patient is having good performances, you take a CT scan. Ensure you have an infra-notch disease. You consider a MSCT followed by surgery or surgery followed by adjuvant treatment. So you can consider, if it is operable, you can consider straight away for surgery. So extensive skin involvement, trismus, cutaneous, I won't say that if any trismus with any of these features, or if you can make out an infra-notch, if the infratemporal fossa clinically, or a temporal fossa, then it's better not to image the patient. You can consider palliation without any investigations. And when you do imaging, you can have any encasement of the carotid artery, skull base involvement. Or if a patient is having any trismus with an M3 node, intention is palliation, and never consider the patient for any CT scan or consider them for induction program followed by an aggressive approach. Now, avoid unnecessary investigations in this group of patients. Now, coming to the borderline resectable disease. If a patient is having, say, in tongue tumors, if the lesion is extending into the posterior 1/3, going into vallicular or lingual surface epiglottis, they are unresectable, even if you consider induction. Either you consider them for a non-surgical approach or you consider them for a palliative, if it is from an oral tongue. But you can palpate with difficulty, much difficulty, but you can palpate post-extend. Then you will be more comfortable if you give chemotherapy. There is no data in such situations. But if you can give chemotherapy, then you can have an R0 resection, better functional outcome, less extent of resection. And if there is a very good response, you can even consider primary closure and you can avoid a flap. That's if the patient develops a very good response. So these are the advantages. These are situations. But if a patient is having a patient who have gingival complex tumors, if a patient is a medial pterygoid involved, lateral pterygoid inoperable, medial pterygoid is potentially resectable. But in such, you can also argue that it's a resectable disease. But if you feel that this will end up in an one resection, then you can consider patient for a induction. So what is an infra-notch disease and a supra-notch disease? We will discuss, we will stop after this. It's running late. I'm sorry for that. So if you have, this is a mandible, you have the condylar process, the lateral pterygoid is inserted into the condylar process. The sir has clearly mentioned that the temporalis muscle is inserted into the coronal process. But the medial pterygoid is inserted into the inner aspect of the mandible, in the ramus, in the angle of the mandible, in the ramus. So this is how the medial pterygoid is lower. The lateral pterygoid is up. So if you have a lateral pterygoid involvement from it extends, I will show you that. The temporalis muscle originates from the entire this temporal fossa, is inserted into the coronoid process. And whereas the lateral pterygoid, so let us take it the lateral pterygoid. This is the lateral pterygoid, has the upper head and the lower head. It arises from the lateral edge of the pterygoid plates and also from the infratemporal surface of the greater wing of the sphenoid. It's inserted into the condylar process. So this is a supra-notch disease. So this is the insertion of the lateral pterygoid. This is the insertion of the temporalis. So once you see the lesion is coming to the level of the insertion of the temporalis or insertion of the lateral pterygoid, or you cannot make out this as in the same. So there is a break in the mandible and the CT scan, you are dealing with the supra-notch disease. Whereas the mandible, it is inserted, it is again have two heads. It have a superficial head and a deep head. And this is getting inserted into the inner aspect of the ramus. And this is medial pterygoid. So this is an infra-notch disease. So here you can see that pterygoid plate destruction is there. You can make out this is the insertion of the temporalis. It is inserted. It is involved. So it's a supra-notch disease. And this patient, they are not candidates for radical approach. And this is candidates for palliation. Yes. So I'm coming to conclusion of my talk. The early disease, gingival complex tumors, you can have radiotherapy or surgery. In tongue tumors, in selected T1, you can surgery. Otherwise, you can surgery. In gingival complex tumor, you can have radiotherapy or surgery in T1 and T2 and 0. Depends on factors that is extrahepatic. What about the functional outcome, the facility for brachytherapy? All these factors which you need to consider, and patient is thinking and patient should decide. Advanced disease in patients who have gingival complex tumors with T3 disease, N1 or N0, or a T1 or a T2 with a node, then you can consider that patient for an chemoradiation. Otherwise, majority of the advanced oral cancer tumors, like tongue tumors or patients who have bone involvement, skin involvement, all consider them for a surgery followed by post-op radiation. All of them are planned treatment, and the operable disease no role for chemotherapy. In minimum post-op dose should be 57.6 grade. Post-op chemoradiation should be restricted to patients with good performance status, patients who have extracapsular extension or margin positivity. No role for target therapy. In stage 4B, generally you consider palliation, but in selected group of patients, you consider radical approach. Yes, I think so everyone getting irritated, but I will wind up this. This is a survival. In stage 1 disease, you have 70 to 80 to 90% survival. So if you can find out the group of patients, you can restrict the treatment to single modality treatment, and you can avoid the mortality. Good local control, which is the primary endpoint of any treatment for head and neck. As you can have stage 3 disease, you can have it's 40 to 50%. It is 50 to 60%. Stage 3 disease. Survival drops from 90% to around 50%. Whereas if you have a stage 4 T4 disease, this is T4, the survival is 5 years survival is around 30 to 40%. So in spite of developments in radiotherapy, in spite of new radiosurgical techniques, newer molecules, for the last 30 years, the 5-year survival of an oral cancer remains plateau, no improvement. And it is in advanced disease, it remains poor. So we may have to individualize patients in the future, the molecular level, to have a good outcome and to treat a personalized personalized approach. So there was, so this is what all I want to say regarding this. So I'm ready to take up few questions. Greeting from Bangladesh. Okay, thank you very much for the for attending the session. Okay, we will have a long association in the future. Yes, this is my email ID, and if you have any questions or you want the slides, because I have put all the evidence in the slides to come, because the total number of slides is around 100, 110, incorporating all the evidences I've mentioned to you. So you can go through that. If you're interested, I can email that. Please note this email ID, or you just WhatsApp me and you send the email ID. I'm happy to send, because my all slides are public properties, public property, because this is meant for the residents. Thank you very much for your patient listening. Okay, I thank the Oncologic Academic Forum for the invitation. I know that the number has, to start with, it was 100. Now with this like survival, it is the number of participants has come to 50. So it is high time that we should wind up. Thank you very much. Any comments from the organizer?
Thank you so much, sir. It's always interesting to hear you, and it shows up, your hard work shows up, and your love for the residents. And it's always a pleasure to hear you. And it's a long talk, and still everybody is eager to hear you. So thank you to Professor Venugopal sir also, and thank you sir also. And it was an excellent session combining the radiology and then the overview of the management by you, sir. So it was excellent. And with the, so thank you so much, sir.
Okay, thank you very much. It's okay. Good night. Okay, and all the best for the exam going residents. Okay, all the best. Okay, thank you very much. If you have any queries, any questions for in head and neck, you can please feel free to contact me. That I can help you. Thank you.
Thank you so much.